Hi, it's 12:30 Thursday. Welcome to Lunch and Learn, another edition of Newton-Wellesley Medical Group Lunch and Learn. We're happy to have Dr. Sheftel here today on the Blizzard version of Lunch and Learn, and she's going to be talking to us about the Echo Lab and clinical pearls and takeaways, and she's got some really cool videos and pictures, so I'm excited for this talk. Next slide, please. I'll put the CME code in the box. The CME code today is FEVTAN. Go ahead and text that in the typical fashion. Next slide. Quick reminders, I'm going to tease next couple of weeks, our vacations and holidays, so we're not going to go on again. This is our last 2020 Lunch and Learn, and we'll be moving on in January to a great talk on by Avner Alifas on it looks like earwax, and then moving on to elbow pain the following week. And as you know, older talks are posted up on YouTube. Just hit the search bar, Newton-Wellesley Medical Group Lunch and Learn. Also, you can still gain 30 minutes of AMA credit if you view these within 1 week. Next slide. Just a tease, we applied for these wellness grants. Some of you have heard me say this a few times, but we want to make sure people take advantage of them because the money's out there for you to use, and it's a use it or lose it kind of situation for us. We have a virtual fitness program, either by downloading the Peloton Fitness app that we'll support for a full year, or online Ship the Fitness staff will do fitness center virtual services. We also have an inpatient physician wellness project that is taking place, and our physician care concierge. Next slide. That's an online service where you can email them. Here's the Peloton app, good for 1 year. If you do have a Peloton and you want to ride with us, we are using that hashtag NWH Strong. Next slide. I was on this morning. There were 61 people, I think, under the hashtag. Physician Care Concierge, now available to not just physicians, but our APPs as well. And it's important. It's a great little service you can use to find out for people around if you need a service such as moving boxes, grouting your tub. They'll send you 3 or 4 different vetted people around that you can call. Next slide. And now I'll be quiet. Go ahead, Dr. Sheftel. Thanks for coming. Appreciate it.
Okay, thanks, Sean. A pleasure to be here. So the topic, of course, is Echo Lab update, clinical pearls and takeaways, and I hope this will be a very practical talk for you. So the big ticket items up for grabs today are valves, typical lesions. I'm going to go through the timing of follow-up echoes, dilated aorta, when to repeat the echo, and then choosing the right stress test for your patient will take up the bulk of the talk. So this is sort of the first take-home slide. What about the timing of follow-up echoes for valves? Well, it really depends on the valve lesion, whether you're dealing with aortic stenosis or aortic regurgitation, and the stage, whether it's mild, moderate, or severe. So, for example, this is a patient of mine, an 89-year-old man with calcific aortic stenosis. You can see that this is a normal, viable trileaflet aortic valve here on the left, but over here you can see that this valve is heavily thickened and calcified with significantly reduced leaflet excursion. We are able to get some quantification on this valve. We can measure the peak velocity that gets converted to a mean pressure gradient, and through some calculations, we can give you an aortic valve area. In this case, the peak velocity is 3.9 meters per second. We then go to our handy dandy table, and I can see that for aortic stenosis, which is progressive stage B, where the peak velocity is about 3.9 meters per second, I would repeat the echo in about 1 to 2 years. Going on to the next lesion, this is a normal appearing mitral valve on the left, and this is my patient with what's called a Barlow type valve. Over here on the right, you can see that these leaflets are incredibly thickened and redundant with excessive leaflet mobility, and they're buckling back into the left atrium and systole. So that's mitral valve prolapse. We can apply a color Doppler onto this, that little flash of blue that comes back in mid to late systole. And I can tell you that that is really a mild degree of regurgitation. So going back to our handy dandy table, we can see that for this mitral regurgitation, which is really only mild, we could repeat the echo in about 3 years. So moving on now, sometimes it's difficult to tell by visual inspection just how severe the MR is. So we can apply these nice quantitative techniques that you might see in some of our echo reports. This is PISA, not the Leaning Tower of, with the proximal isovelocity surface area method. And we can get these fancy terms like the MR ERO, that's the effective regurgitant orifice area, and the regurgitant volume. And the reason that we do those things is because that's how we grade the mitral regurgitation, as you can see here. And that really will guide and inform the decision for surgery. That's why it's important to get quantitative. Now, this is just to show you that in our lab, we can do some nice two-dimensional imaging. We can do some nice transesophageal echo. This is 2D imaging. This is a very ratty mitral valve with a partial flail and this very eccentric jet of MR. We can also get these nice three-dimensional images in which we're looking at the mitral valve en face, and then we can create these beautiful reconstructions using the Mitral Lab Navigator, showing in this particular case prolapse of certain segments or scallops, as we call them, in the mitral valve, that really helps the surgeon to decide sort of the nature of the repair. This is a patient of mine with a bicuspid aortic valve. Of course, that's a valve that has two leaflets instead of one. And you can appreciate the pretty pictures here, the aortic regurgitation, the AR jet in diastole, which is refluxing into the left ventricle. We can also, again, get more quantitative in our lab. We have fancy ways of assessing the severity of the lesion by looking at things like jet deceleration rate, and we can measure the width of the jet, all of this to get more quantitative. So in this case, in the patient with the bicuspid aortic valve, I thought the mild was leak. I'll wait to 2 years to repeat the echo. Now, there are some important caveats to this, which is the following. That trace for mild MR is common. So if the mitral valve is structurally normal and the left atrium and the left ventricle are normal, you don't necessarily need to do a follow-up echo. This table really applies to valves that have some anatomic structural abnormality, like mitral valve prolapse or abnormal thickening or a bicuspid aortic valve. Obviously, if the patient comes in with symptoms, you might, that are suggesting a flail leaflet or something like that, you may want to do the echo earlier, but this is a general guide. So moving on now to the aorta, it's important to realize that we don't get the whole candy cane. What we get are different segments of the aorta. We can see the proximal ascending aorta. We can see a bit of the arch and some of the abdominal aorta. But what we really focus on in our echo reports is this area right here, and that would be the aortic root, the proximal ascending aorta, as you can see here. So when we talk about the root, we are largely referring to the sinuses of Valsalva. That's these outpouchings here. And you can see that we're also measuring the proximal ascending aorta, and we do that very carefully on echo. We can make these nice measurements from a reference landmark. Now, just a couple of words about the aorta. Interesting to me, it enlarges with age and increasing body surface area, as you can see here on the right. And there are risk factors like hypertension, atherosclerosis, and smoking. There are normative values that have been published. A thoracic aortic aneurysm is really an increase of greater than 50% of the normal arterial diameter, or according to Dr. Isselbacher at the MGH, greater than 45 millimeters in diameter. Now, there are sporadic causes that may just be related to hypertension and so forth, and familial syndromes. Of course, there are genetic causes. What I often see is bicuspid aortic valve with its associated aortopathy, Marfan's, Ehlers-Danlos, Loeys-Dietz. Now, take-home slide. I told you there were take-home slides. The timing of the surveillance echo really depends on the aortic diameter, the growth-associated conditions. So there's a number of society guidelines, and there was really no uniform consensus. For sort of the sporadic types, it's really sort of physician discretion. In general, if the size is greater than 4 on the first echo, greater than 4 centimeters, you can repeat the study at about 6 months. Just make sure it's not growing too quickly. Once the size gets over 4.5 centimeters, annual surveillance. But again, this is going to be influenced by age, family history, and risk factors. This is just a nice journal that came into my mailbox the other day that I thought I'd throw in there, just showing that there's sort of no consensus in terms of guideline recommendations, but just in there for your own frame of reference. So moving on to the bulk of the talk here, stress test at Newton-Wellesley Hospital. We offer several types. We offer a plain exercise tolerance test. We offer 2 types of nuclear stress tests, and we offer 2 kinds of echo stress tests. This is sort of an important foundational slide. Stress testing really exploits the ischemic cascade. So when you have a stenosis of 50%, 70% or more, what happens as you start to put that patient on the treadmill or through exercise, the first thing that happens is you start to see abnormalities of perfusion. Of course, we capitalize on that with our nuclear stress tests. Then we start to see abnormalities of relaxation or compliance. And then we start to see systolic dysfunction. We capitalize on that with our stress echoes. And it's really not until the bitter end that we start to see ECG changes and you look up and your patient's complaining of chest pain. Now, here's just some general principles about stress testing. Exercise is always preferred. It's simply more physiologic and it carries a lot of prognostic information. You really want the patient to achieve at least 80%, ideally 85% of the maximum predicted heart rate, which is really 220 minus your age. Now, in the case of somebody who has a suspected CAD, this is really most useful where there's a pretest probability of over 15%. Stay tuned. And we typically do hold meds so that we don't blunt any ischemia. Now, in situations where there's known CAD and you're really doing the test to stratify or assess for residual ischemia, we typically in those circumstances do ask patients to take the beta blocker, but again, there's provider discretion. Now, somewhat counterintuitively, and it took a while for me to figure this out, a normal stress test doesn't necessarily predict myocardial infarction. That is sort of a complicated multifactorial phenomenon that really has to do with plaque erosion and rupture. So choosing the right stress test, 3 basic principles. Number 1, what is the pretest probability or clinical likelihood of CAD? Number 2, is the ECG interpretable for ischemia? And number 3, can the patient exercise? So taking these in turn, take-home slide. You gotta love these take-home slides. I did this for you. How to estimate the pretest probability. So this is a very nice, handy slide that comes out of 2019 European guidelines, in which we can see that age, sex, and chest pain are the things that we're going to look at to determine pretest probability. And if you can't remember how to grade or how to think about typical, atypical, or non-anginal chest pain, you can go to handy dandy table number 3, which is going to remind you how we define those entities. It turns out that and by the way, dyspnea is now recognized as an anginal equivalent. We never saw this before. It was an old Diamond Forrester classification, but now we all knew this. We can also think about shortness of breath as an anginal equivalent. Now, it turns out that testing is most beneficial in patients with a pretest probability of about over 15%, which would represent these dark green areas. Now, we can refine the pretest probability by taking it a step further. And now there's a new concept that has to do with the clinical likelihood of CAD. So now, beyond looking at just sex, age, and nature of symptoms, we can look at things like risk factors, dyslipidemia, diabetes, hypertension, smoking. What is the risk of my patient? We can also begin to look at coronary artery calcium, which is getting a lot of press. And so we move from the notion of a pretest probability of disease to a clinical likelihood of CAD. And so there's an association between the severity of coronary artery calcification and myocardial ischemia. So for example, if you have a CAT score of greater than 400, you have about a 2 in 4 chance of having ischemia on a nuclear stress test. So, question that often comes up, should I stress my asymptomatic patient? Well, the answer to that is generally not. But the guidelines say that if you have an asymptomatic patient with diabetes, peripheral vascular disease, a strong family history, or when you might have subclinical atherosclerosis like a CAT score of over 400, then you certainly could consider a stress imaging test. Now, what about if your patient's had revascularization? So for example, let's say your patient is 5 years or so post-CABG or 2 years or so post-coronary stenting. Well, the guidelines say that stress testing may be appropriate on a one-time basis for the asymptomatic patient. But if your patient's doing well, you don't necessarily need to do that stress test year after year. And this is a nice app that I use with my patients from the Cardiosaurus CardioSmart, which is just a lot of fun showing how stents are implanted there in the artery. So number 2 is the ECG interpretable for ischemia. Well, an ECG is generally considered uninterpretable if there's, greater than or more than 0.5 millimeters of ST depression. There's sort of this host of entities, in which case we really need to turn to imaging. And so that is shown here. These are all my patients within the last month. This lady was on digoxin. See the nice Salvatore Dali mustache there. Left ventricular hypertrophy with all the secondary repolarization abnormalities, left bundle, of course, and WPW, and all of these need imaging. Now, remember that no imaging is needed for right bundle branch block. And the reason for that is that typically we interpret ischemia in the inferolateral leads, 2,3F and V4 through V6. But remember that ST depression does not localize ischemia. On the other hand, ST elevation might and would be a marker for transmural ischemia. Now, the next thing, can the patient exercise? The answer is you really want the patient to have a certain functional capacity before you refer them for an exercise test. So they've got to be able at least to do some of the activities of daily living, because that's usually the level, the workload at which stress testing starts. And really, again, we want the patient to be able to achieve 85% of the maximum predicted heart rate. And as I mentioned before, exercise preferred whenever possible because of the functional prognostic information that it gives. So let's move on now to some of the specifics. So first test, of course, is just a plain exercise tolerance test. So what about that? So it's a quick and easy test, of course. Do you need to be NPO? No, you don't. And we do typically a standard GRIS protocol over here where they start at about a 10% grade, about 1.7 miles per hour. We can also do a modified GRIS protocol if people have orthopedic limitations and such. Again, we do a symptom limited test, meaning the patient gets exercise as long as they want, or to try to get to that magic number of 85% maximum predicted. Of course, you need an interpretable ECG, and we're looking for a host of things like symptoms, ECG changes, arrhythmias, exercise tolerance, and blood pressure and heart rate response. We can also get some prognostic information. You've probably heard of the new treadmill scores. This really has to do with exercise duration, ST deviation, and the angina index. Now, sometimes things get a bit hairy in the exercise lab. The other day I was there and patient ran into polymorphic VT. So what did we do? We ushered the patient straight to the cath lab. Turned out the patient had a chronic occluded RCA, but nicely enough, it was well collateralized, and the patient got a stent with a very nice angiographic result. So let's turn now to some of the nuclear stress tests in turn, exercise and pharmacologic. So let's talk first about the exercise nuclear test. So the principle here, of course, is an increase in myocardial oxygen demand. So must the patient be NPO? Yes, for about 4 hours. So the patient comes into the lab and gets a rest dose of the radio tracer, then goes under the camera, the D-SPECT camera. Then the patient exercises, and within about 1 minute before termination of exercise, gets another stress dose of the technetium-99 sestimib. Sestimib is the ligand. So the radioisotope reflects, and then they go under the camera one more time. So the radioisotope, the technetium, reflects myocardial blood flow, and SPECT imaging uses the gamma camera to detect the photons that are being emitted by the patient, and of course, then an image is generated. Now let's talk a little bit about the other kind of nuclear stress test that we offer, the pharmacologic stress test. And the principle here is not a supply-demand mismatch problem, but that we're increasing coronary blood flow. So once again, the patient must be NPO for 4 hours, and they get a rest injection through the intravenous line of the radioisotope technetium. They go under the camera, and then they lie there on the stretcher, and we give them an intravenous dose of regadenoson, otherwise known as Lexiscan. And then they get a second stress dose of the isotope. They go into the camera. So the regadenoson is a coronary vasodilator. It is a selective A2A receptor agonist, and what it does is it increases blood flow to normal coronary arteries, and it steals it from stenotic vessels, and it thereby creates a heterogeneity of perfusion. Now, a couple of things that we prep our patients for: they can't have caffeine or theophylline because it can block the receptor. And this test is contraindicated, although it's pretty specific for that A2A receptor. If somebody's got really bad asthma or uncontrolled asthma, it might have a weak affinity for the A2B receptor. So we caution, it's okay to do this in mild or well-controlled asthma, but if somebody really comes to the lab wheezing, we won't do the test. And it is contraindicated as well in seizures because it can lower the seizure threshold. So we compare rest and stress images. As you can see here, the pretty pictures. This would be an example of an ischemic defect where we see a void here, but then we can see that fills in on these various orthogonal views, and a reversible defect would represent ischemia. And here you can see that we can also give you a gated left ventricular ejection fraction. We can look at wall motion and thickening, all based on the gating from the EKG. Perfusion abnormalities correspond to coronary anatomy, so that you can see here that if we get, for example, anteroapical perfusion defects, that would indicate that we might have an obstruction in the LAD, left anterior descending artery. Some of the pitfalls of nuclear perfusion imaging: we can get into trouble with some attenuation artifacts like breast and diaphragm, a little bit of reduced spatial resolution. There's also radiation exposure. We typically like to not do these year after year. We like to avoid it in premenopausal women. But turning on now to stress echocardiography, again, there are two flavors: exercise and dobutamine. Let's take the exercise first. That's Mary Coates, our chief technologist. So patient have to be NPO? No. Now, this is especially useful when a patient has shortness of breath and you're wondering, could there be something else going on? Maybe it's not ischemically mediated. So the beauty of this test is that we can do some screening baseline echo images, and we can look at diastolic function. We can take a look at the valves. We can look at the pericardium, peer pressures. We get a host of information. And I remember once somebody came in the lab and they had a left atrial myxoma. So you pick stuff up. There's really no appreciable radiation, but the image quality can be limited, and sometimes it can be challenging to interpret the images. This is just an example of how we do the test. We get some resting echo images in 4 orthogonal views. The patient then exercises, and then within 60 minutes, they get off the treadmill, they get onto the stretcher, and we compare the rest and stress images side by side. As you can see here, this is an example of a normal exercise echo pre-heart rate. Exercise heart rate is 60, 60-second acquisition post-exercise. And what you appreciate is all of these walls are moving very nicely, and they're thickening well, and the LV cavity is getting smaller, and all of this is well, and this is normal exercise echo. Now you'll notice this kind of funny white milky stuff, and that is not iodinated contrast. That is something called definity. So you may have seen this in some of the echo reports. And what definity is, it's not contrast. It's these small microbubbles that are composed of this gas and are encapsulated with this shell. Important to realize when you tell your patients there's no iodine, there's no gadolinium, there's no sulfur components. It causes a very, very, very rare type of allergic reaction. I've never seen it. It causes a bronchospasm, but we would treat it like an allergic reaction. So that's definity. So the next kind of stress echo is a pharmacologic stress echo. That's dobutamine. Do they have to be NPO? Yes. Dobutamine, of course, is a synthetic catecholamine, which stimulates the beta-1 receptors. It's a positive inotrope, so it increases heart rate and contractility. We give stepwise infusion over in graded doses every 3 minutes to about 85% of the maximum predicted heart rate. And we get about 4 sets of images. A little bit technically demanding, requires a nurse and a lot of staff to do. And so we typically try to reserve it for patients that have contraindications to the easier to perform Lexi scan. Of course, when you're giving a positive inotrope like that, you can get into trouble with arrhythmias. As in nuclear land, again, if we see an inducible wall motion abnormality, for example, in the inferior wall, the basal to mid, it might give a tip off that we have a lesion in the right coronary artery, and that would be helpful to the interventional cardiologist. What about sensitivity and specificity? Well, a plain treadmill test has a relatively low sensitivity and a higher specificity. Now, when we compare SPECT, nuclear, and stress echo, they have similar sensitivities, but stress echo has a higher specificity. So these recent numbers that I posted down here were from a recent meta-analysis from the European Heart Journal. Generally speaking, I think of nuclear stress test as slightly more sensitive, and the echo stress test is a little bit more specific. Now, here's an interesting article and food for thought. A normal stress test may be very reassuring in the short term in assessing the likelihood of obstructive CAD or the magnitude of ischemia. But here's the point. The long-term risk may still be high. So if you have a 65-year-old diabetic smoker who comes to the lab and they can't even walk on the treadmill, and we tell you from the lab they had a normal stress test, no perfusion abnormalities, that still doesn't necessarily mean that patient's out of the woods. You have to think globally about your patient, consider a whole host of factors when you're thinking about that patient's risk. And so in summary, you're choosing the right stress test. I made up this table. So for the low-risk patient, you're going to want to go with just a plain treadmill test. It's cheap and accessible. You're going to get a host of information about exercise tolerance, symptoms, arrhythmias, blood pressure response. Kind of has a low sensitivity. You do pick up weird things like the polymorphic VT, so it's not a bad test. When you have an intermediate to high-risk patient, slightly higher global cardiovascular risk, you're going to want to go to the stress imaging test, and you have echo and nuclear. So with echo, there's no radiation. I like that. Particularly useful, I find, for dyspnea, because we can look at alternative cardiac causes, not just inducible ischemia. Problem with echo is the image quality can be a bit suboptimal, poor acoustic windows, but again, we can use definity, which is not contrast, and has slightly higher specificity. With the nuclear world, we have the radiation exposure. We can get into trouble with artifacts, breast and diaphragm, slightly higher sensitivity. I try to avoid this in young premenopausal women, and I try to avoid getting a study every year because of the radiation exposure. So here's the final stress test checklist that I made for you guys. You got to think about what's the patient's pretest probability, or moving on to the new concept of the clinical likelihood of CAD, where you're looking at risk factors, coronary artery calcium scores. Intermediate is most appropriate for a stress imaging test. So if it's low risk, you go to ETT. If it's intermediate or high risk, you can go to a stress imaging test. You've got to know if your patient exercises. Use that table of metabolic equivalents. If not, you've got to go to pharmacologic stress. Is the ECG interpretable for ischemia? If not, you've got to go to an imaging test. If you're trying to make the diagnosis of CAD, you're going to want to hold a beta blocker. If the patient has known CAD, we typically take the meds. If you have a female, especially premenopausal, go for an exercise echo, avoid the radiation. If you have somebody with real short breath, consider an exercise echo. You get a host of other information. And do we test the asymptomatic patient? Rarely. So at the Newton-Wellesley Cardiac Ultrasound Lab, we have a full array of cardiac imaging. We can give you a transthoracic echo. We can do transesophageal echo. We can do 2 flavors of stress echo, exercise, and dobutamine. And not only for ischemia, but we can do even for diastolic function, even for valve function. We have 3-dimensional echo, and we will be getting into some strain imaging. We already have the software that's very useful for cardiomyopathies to look at thickened hearts and decide if it's amyloid or hypertensive heart disease, and also extremely important in the oncology world to detect subclinical LV dysfunction. So during this era of physician burnout, I thank you. And if you're feeling lonely or looking for love, you can access this video and see the kissing mitral valve. Thank you.
Thank you. Oof, that was a whirlwind.
Yeah.
I don't think you took a breath that whole talk. I'm not quite sure. Thanks so
Here's,
much. If you guys have any questions, you can throw them in the chat box. I wanted to ask a question regarding the workup, because sometimes we send folks over and they have such a high probability that you guys skip over the stress testing. And it used to be back when I started, they go right to cath, but now you guys are using the CT angio a lot. Can you talk about how that works into your kind of workflow with these patients?
well, if somebody comes into the lab and we really suspect that there's something is wrong and that the patient could be hot or acute, typically in that scenario, we usually know it. We send them to the ED, they check the troponins, and more often than not, the patient just goes straight for gold standard coronary angiography. But I have a lower and lower threshold to use coronary CT angiography. Sometimes we get an equivalent exercise test, a plain ETT, because the sensitivity is so low. And if, again, if I have somebody who's sort of intermediate risk, I have a low threshold to get a coronary CT angiogram. Sometimes you could go straight to that instead of doing a functional test. But again, stress test does give you the functional information. It localizes the ischemia. Sometimes the coronary CTs can look like a higher burden of disease than you'll see on gold standard angiography because it really looks, I think, at the wall. So to lower threshold to use that, using it more and more. But if we suspect that somebody's higher risk, we will often adopt that patient and go and recommend that kind of imaging.
Okay. I don't see any other questions in there. We want folks, I'll put the code in here if people missed it, but you can see it up on the slide there. Again, this is our last talk until next year, until January. So we want to wish everybody a happy new year and happy vaccination day. In about 30 minutes, we'll be giving our first vaccination at Newton-Wellesley for a disease that 1 year ago nobody ever heard of. So that's something I would say. And we hope everyone has a safe and happy holiday season. And we'll see you back at the end of the year. Thanks so much. Bye.
Thanks, everybody.